Thank you very much. It is indeed a pleasure. Can everybody hear me?
Yes, we can hear you.
Wonderful. Thank you very much. So I've been assigned this topic of multimodality imaging of heart failure. Of course, this is a major topic. It's not a small thing which can be compressed in a short period of time. So I can only give a very brief overview, and there are other talks which will follow, and they will carry over some of the topics we are discussing. So as Dr. Pacholia has set the stage, heart failure is a multifaceted heart disease. So to summarize in a short way, I can say that heart failure is the inability of the heart to pump adequate blood for appropriate perfusion of various organs in the body. And this can be either acute or chronic, or acute worsening of the chronic heart failure, which is a quite common reason for presenting of the patients to the emergency department. It can be systolic or diastolic, or even sometimes combined. Both there is a systolic dysfunction as well as diastolic dysfunction of the heart. More commonly, this is a low output condition where there is decreased cardiac output, but there are conditions where there can be heart failure with high output, for example, in COPD, sepsis, thiamine deficiency, and severe anemia. It can be, the multiple conditions can give rise to heart failure. Valvular dysfunction, different kind of valve stenosis, valve regurgitation. It could be myocardial in origin, ischemic, non-ischemic, conduction abnormalities, and arrhythmias. And there is the severity is over a very wide range, and it can range from subclinical left ventricular dysfunction to florid heart failure and cardiogenic shock. And underlying conditions can be reversible, partially reversible, or irreversible. And also it has been discussed quite extensively by Dr. Pacholia that the symptoms of shortness of breath, impaired exercise capacity, fluid retention, and systemic congestion, pulmonary edema, pleural effusion, and ascites, they overlap with several other conditions, pulmonary conditions, hepatic disease, and several other systemic conditions. So imaging of the heart failure is essential to identify and confirm the diagnosis of heart failure, to assess the severity of heart failure, and also to determine the underlying etiology and contributing factors, to guide and monitor therapeutic interventions, and for short-term and long-term prognostication, and to determine the need for advanced therapies, such as need for mechanical support, intra-aortic balloon pump, LVAD, or heart transplant. It should be used, the imaging modality should be used in conjunction with clinical exam, various biomarkers, which have been discussed quite succinctly, and hemodynamic evaluation, which can include blood gases, cardiac output, MbO2 or maximum oxygen consumption, as well as non-invasive and invasive hemodynamic evaluation, exercise capacity, and 6-minute walk test, and endomyocardial biopsy in selected cases. So for imaging, we have a wide spectrum of imaging modalities, ranging from very simple, readily available, to highly sophisticated and complex modalities. Appropriate utilization of imaging modality requires a thorough understanding of the pathophysiology and hemodynamics of the heart failure. Oftentimes, different imaging modalities can be used to obtain the same information, but there are several niche areas where a specific information can only be obtained by a specific imaging modality. The choice of imaging modality should be driven by the clinical questions we need to address, the availability of the technique, and the availability of the expertise, patient safety. Of course, cost considerations are quite important. So these factors play into into our choice. So this cartoon is a diagrammatic representation. Now, these are not up to scale. So these are the major imaging modalities available to us: echocardiography, nuclear imaging techniques, magnetic resonance imaging, cardiac catheterization, and non-invasive coronary angiography. So there are several questions which can be answered by any of the technique, but then there are several questions like the etiology of the heart failure, whether diastolic dysfunction is contributed by amyloidosis or by sarcoidosis. For those, you require very specific tests which cannot be carried out by every single modality, and these would be considered as the niche areas. Now, there are multiple speakers who are going to talk in detail about echocardiography, MR, CTCA, and as well as some aspects of nuclear imaging. So I will focus on the areas where nuclear imaging can be helpful in patients with heart failure. Now, I'll focus on the areas which are kind of unique for nuclear imaging, where the information provided by nuclear imaging is something which cannot be obtained readily by other imaging modalities, like viability, inflammation imaging in sarcoidosis, infiltrative conditions like cardiac amyloidosis, dysynchrony imaging, which can be dysynchrony can be important contributor to left ventricular dysfunction in patients with pre-existing left ventricular dysfunction, and identification of dysynchrony and its correction by appropriate electrophysiological technique can result in a substantial improvement in the condition of the heart. Cardiac neuronal imaging, another important area, which is again unique to nuclear imaging, plays an important role in the prognostication of patients with heart failure. I will briefly show some data on that. So regarding some of these modalities, now again, it's very hard to cover them in detail. I will focus on one aspect, which is technetium pyrophosphate imaging for the detection of amyloid. I'll show you some cases, and that will be illustrative how this relatively simple modality. Now, many of you would recall technetium pyrophosphate imaging is nothing new. This has been in existence for almost 4 decades now, and this was used quite extensively in the past for myocardial infarction imaging, which we don't do right now because there are other modalities have completely surpassed the identification of myocardial infarction. We need to identify it within minutes or as soon as possible, rather than over hours or days, which pyrophosphate would require. But it has found a new application, that is technetium pyrophosphate imaging. So this is a case I'm showing, a 66-year-old woman who her complaints were persistent shortness of breath and exertion for the last 1 year, which was getting worse. She had long-standing hypertension, depression, hypothyroidism. Cardiac exam and ECG were unremarkable. Echo showed moderate pulmonary hypertension and tricuspid incompetence. Her palm stress was normal. Right heart catheterization showed normal LVDP and PA pressure, and she was suspected to have amyloidosis, and she was sent for amyloid imaging. Now, these are the images. This technique is primarily, although we can do SPECT imaging as well, but primarily based upon planar imaging. So the planar images are shown here: anterior view, left anterior oblique view, left lateral, and right anterior oblique view. This is just the inversion of the scale. And as you can see, we can see the bones. This is a bone-seeking agent, and the skeletal system is image, but there is no uptake in the heart. And we can, on the right-hand side, we are showing the quantitative way of analyzing the images. You can draw a region of interest over the heart and the contralateral right side. And this ratio was 0.98. That's a normal. So this study is negative for technetium pyrophosphate uptake. So this effectively, the sensitivity of this technique for detection of TTR amyloidosis is, which is the most common form of cardiac amyloidosis, is in the range of 98 to 99%, and so is this specificity. So highly sensitive as well as specific for the detection of this rare condition. Now, this is the same patient's image. We are just showing zoomed up. You can see it more clearly that the area where there is a heart, there is no uptake. So this is another case. This is, the presentation is somewhat similar, but with little differences. 74-year-old woman who was referred by an outside cardiologist for persistent and bothersome diastolic heart failure. She had long-standing hypertension, hyperlipidemia, and glaucoma. She had chest pain 2 years ago and underwent coronary artery disease workup, which was negative. Magnetic resonance imaging was carried out of the heart. It showed left ventricular hypertrophy. Uh, Her symptoms of non-exertional atypical chest pain persist, and her shortness of breath has been getting progressively worse, requiring multiple office visits for these complaints over the last 2 years. So she was diagnosed with diastolic heart failure and referred to our advanced heart failure service for further evaluation. So her exam was unremarkable other than hypertension. Echocardiogram showed severe left ventricular hypertrophy, preserved ejection fraction, moderate diastolic dysfunction, and a mild intracapillary gradient, which would not explain her symptoms, and pulmonary hypertension. She was on multiple antihypertensive agents, and this is the EKG. EKG is unremarkable overall, but in the face of significant left ventricular hypertrophy, we note there is an absence of left ventricular hypertrophy on the electrocardiogram. She underwent technetium pyrophosphate imaging. And these are the images: anterior view, left lateral, right anterior oblique view, and left anterior oblique view. Now, unlike the last patient, which was normal, this the heart lights up. It's a very significant uptake of radiotracer in the left ventricle, as we can see here. These are just the same images shown in the inverted scale, which we can see it very clearly. So the uptake in the heart is even more intense than the bone uptake. So quantitatively or semi-quantitatively, we call this as a grade 3 uptake, which indicates that the tracer uptake is more than that of the bone uptake. And these are the close-up of the images, and again showing a very profound tracer uptake in the heart. The heart to lung ratio shown here was abnormal, 1.65. Normal is 1.5 or below. And this is the whole body image. Again, we can see there is a radiotracer uptake. Apart from the skeletal system, only in the heart, there is no other organ which lights up. That's a urinary bladder, and that's a normal finding because this is excreted by the renal system. Now, you can do the SPECT imaging as well, which we did on this patient, and these are the SPECT images with and without attenuation correction. And there is actually the whole myocardium lights up. So this is a case with a pretty severe abnormality with a very profound radiotracer uptake. And indeed, she was confirmed to have a diagnosis of TTR amyloidosis of the heart, and she has been started on a treatment which is available now, and we'll see how she does over a period of time. This is yet another example of a positive study, little bit less intense uptake compared to the last patient. This is a 93-year-old male who presented with recurrent bouts of diastolic heart failure, and he was suspected to have senile amyloidosis of the heart, which was confirmed by technetium pyrophosphate imaging. There is a very intense, there is intense uptake, but less intense compared to the last patient. This would be grade 2 uptake, and the ratio turned out to be 1.45. These are the SPECT images. Again, we can see very clearly the radiotracer uptake in the heart. So moving on to another area, this is one area where nuclear imaging does much better than any other imaging modality, including magnetic resonance imaging. Echocardiogram can raise a suspicion, but is in many cases, in both these cases which were diagnosed with TTR amyloidosis, echocardiogram was not necessarily diagnostic for TTR amyloidosis. Now, another area is sarcoidosis. Sarcoidosis is an inflammatory condition, and this is an example of a 45-year-old male patient who had systolic heart failure with ejection fraction of 35% for the last 2 years, and the heart failure was progressively worsening. And this is a combined imaging myocardial perfusion obtained with system AB And the second row shows FTG by PET-CT imaging. So what we see here is enlarged and hypertrophied left ventricle, but there is no definite perfusion abnormality. There is little less radiotracer uptake in the inferior wall. That's a diaphragmatic attenuation, but no perfusion abnormality. There was global severe hypokinesia. Ejection fraction was 34%. On the FTG images, we see very intense and very localized radiotracer uptake in the lateral wall. The entire lateral wall lights up. These are the MIP images, fused PET-CT images. We can see the uptake in the heart, and also there is an uptake in the calcified lymph nodes. So there was extracardiac sarcoidosis as well, involving multiple lymph nodes as well as lungs, apart from the cardiac uptake. So this patient, the biopsy showed the patient has cardiac sarcoidosis. Again, nuclear imaging modalities can be considered as a very important technique, much better than echocardiography, or as well as magnetic resonance imaging. You can see delayed enhancement in patients where there is a significant fibrosis, but inflammation is something unique for nuclear imaging. Now, another area, which is adrenergic neuronal imaging. This is an example of iodine 123 MIBG imaging, which looks at the radiotracer uptake. Normal radiotracer uptake, you should see in the normal heart, there is a uniform radiotracer uptake. Now, in patients with heart failure, there is a decreased radiotracer uptake, and worse is this abnormality, worse is the outcome of these patients. A very powerful prognostic technique. This is a study which was conducted, and it showed the prognostic value. These are 3 patient studies shown here, the planar images in the anterior view. This is a 64-year-old male with New York Heart Association class 2 failure. Left ventricular ejection fraction was 30%. There is some uptake in the heart, and the heart to mediastinal ratio, which is a quantitative way of looking at it, was 1.67. This patient did well over 2 years with no cardiac events. Yet another patient, ejection fraction is 33%, but we can see there is very little radiotracer uptake in the heart. His heart to mediastinal ratio is 1.38, and that is significantly abnormal. He died of sudden cardiac death 8 months after the study was done. Yet another example of a different patient. Again, ejection fraction is 25%, not very different from the remaining 2 patients. His heart to mediastinal ratio is even more abnormal, 0.96. That is very abnormal. Practically, there is no uptake in the heart. The background is hotter than the heart. So this patient died of heart failure progression within 8 months from the follow-up from the study. Again, indicating a very powerful prognosticator. Worse is the uptake of MIBG, worse is the outcome of these patients. Now, the question whether successful treatment would result in an improvement in the radiotracer uptake, that is unknown. Can treatment be guided? Can you select patient for ICD implantation, which is done quite commonly in patients with impaired left ventricular function, rather than relying upon ejection fraction? Can you, those remain unanswered question, but the studies have shown it to be a powerful technique. So to wrap up my presentation, although I focused up, as I mentioned before, on a relatively small niche of where nuclear imaging can be used, cardiac imaging is an integral part of the evaluation of patients with heart failure. A wide spectrum of cardiac imaging modalities are available, but proper utilization of imaging requires a proper understanding of the pathophysiology of the heart failure, as well as understanding of multiple different modalities. And the choice of imaging modality should be based upon the questions we are trying to address. The question can be confirm the diagnosis of heart failure. A regular simple echocardiography can readily do that, or whether this patient would benefit from revascularization, or whether this patient has a rare conditions like amyloidosis or sarcoidosis, then you would choose a technique based upon the question. So it's important that we pay attention to all these aspects of utilization of imaging modalities in patients with heart failure. With that, I'd like to conclude my presentation and thank you very much. Over to the chairpersons.